Haifa and Marini also, but Marini will not be joining in the presentation due to an appointment. So I'll be presenting her part, and me and Haifa will be presenting dividing her part. And we also be presenting a physical examination, and we will be talking about the bioethics. Okay, so starting off about the patient. So for identification data, my patient's name is Salah bin Hussein, a 66-year-old Malay male who lives in Terengganu. Um, he worked as a farmer, but he's retired at the moment. And his date of admission was on 27th of June 2023. We cloned him on the 3rd of July 2023. Yes. So then we took the information from his son, who's Muhammad Hanif, 31-year-old Malay male. Malay male, yes. So starting off with the chief complaint, the patient presented to the emergency department of Hospital University Science Malaysia due to shortness of breath that started 3 days prior to admission. We starting off not 3 days, but even earlier than that, due to want to clarify some symptoms as well. That started like the productive cough. So the patient developed on the 22nd of June 2023 an onset of productive cough upon waking up in the morning. It was on and off. It had it was associated with whitish sputum, and he had difficulty expectorating the sputum. And otherwise, the sputum had no foul smell and there was no blood in the sputum. It lasted for about 2 to 3 hours. Patient's son gave him cough syrup to try to alleviate the symptoms of cough. And that was his first time experiencing prolonged cough that lasted for like from 2 to 3 hours, and it was on and off. Also, the patient developed fever around the same time in the morning. His temperature was 37.8 Celsius at home. And the onset was sudden and intermediate nature and not associated with chills or rigors. Patient took paracetamol, and which was also bought from the pharmacy, which partially resolved the fever. Moving on on the 23rd of June 2023, the cough and fever had improved. 3 days prior to admission, which was on the 24th of June, on 9 a.m. in the morning, he experienced his first episode of shortness of breath upon waking up with difficulty in breathing. The symptoms were relieved when the patient lay on his left side and were not aggravated by any factors. The episodes of shortness of breath lasted for approximately about 10 minutes. At 2 p.m., patient visited a private clinic where vital signs were taken, but no further investigations were conducted. And he was prescribed medications and antibiotics, which provided some relief. However, on the 25th of June 2023, which is 2 days prior to admission, 7 a.m. in the morning, the second episode of shortness of breath occurred, was similar to the previous episode. Which was similar to the previous episode. It lasted for 10 minutes and caused him to wake up from his sleep. The medication from the private clinic did improve the symptom and continued to relieve the symptom by lying on his left side. However, on the 26th of June, also in the morning at 8 a.m., third episode of shortness of breath occurred, lasting for another 10 minutes. Medication didn't alleviate the symptoms, so the patient was brought back to the same private clinic at 3 p.m. The vital signs were taken and the patient appeared pale. Advised the patients in the private clinic, they advised him and his family to bring him to the hospital as soon as possible. On 7 p.m., he arrived at the emergency department of Hospital University Science Malaysia with a car drove by his son and accompanied by his children and wife. On the moving on, upon admission in the emergency department at USM, patient was conscious but lethargic, with difficulty breathing and low-grade fever. He was prescribed paracetamol and IV Dazuson, oxygen, Also oxygen was administered via nasal prongs, and an IV drip was set up. Lung investigation and chest X-ray were performed, revealing a massive left pleural effusion. The left pleural tapping was done to drain the effusion. He was later submitted to Ward 7S for further management. The next day, on the 27th of June 2023, around 8 a.m. On 2000, on the 27th of June, during his current admission, he was conscious level was decreased and his blood pressure was elevated. I started on amlodipine to manage the blood pressure. He received 3 liters per minute of oxygen via a nasal prong. His left lung had reduced air entry, but his oxygen saturation remained good. Received Ryle's tube feeding as well from nutrition. Due to the resistance of the left rear effusion and the presence of a left pneumothorax that was found by the chest X-ray, a left chest tube was inserted to manage his pain. Mr. Sarah was given IV tramadol, 50 milligrams, 3 times daily as an analgesic. On the 28th of June 2023 and to the 2nd of July 2023, in the following days, his conscious level didn't improve. There was reduced air entry in the left lung field resisted. On the 3rd of July 2023, which is the day we cloaked him, patient wasn't conscious with GCS out of 3 out of 15. No signs of improvement. Blood pressure was low, heart rate was elevated, and temperature was 37 under high flow oxygen mask. Left lung field still persistently reduced air entry, and he continued to receive IV Dazocin for another week. Moving on, but before we move on, I wanted also to highlight on the 27th when he was brought a DNR form to be signed, and we will talk about that later on. But it was on the 27th of June.
All right, it was my turn to present. Before that, can I ask if my voice is clear enough to be heard?
Clear.
Yeah. All right. So moving on for past medical and surgical history. So we sorted into the timeline. So I hope the other can have the idea of the disease progression itself, so we can see how severe this and complicated was this case was. So started in November 2021 up until December 2021, we can say the end of the year. It was his first admission at Hospital Pulau Pinang for 1 week, where transurethral resection of prostate and orchidectomy was done for the treatment of prostate cancer, where the first diagnosis of him having prostate adenocarcinoma was diagnosed. So after the admission in Hospital Pulau Pinang and also all the surgical intervention was done, he was then discharged and was planned to refer under HUSM Oncology for radiotherapy treatment for the cancer management. So on March 2022 up until May 2022, he was mentioned by his son that patient was completed his 23 cycles of radiotherapy under HUSM. However, they noted he had some neurologic presentation due to post-radiotherapy, where he had episode of confusion and also right-sided weakness 1 month after the radiotherapy was completed in April 2022. So it was planned for CT brain done at Hospital Sultan Hamid Zahira, Terengganu. And after the CT brain was done, it was said that the result of the CT showed there is a presence of brain metastasis. So earlier into 2023, which is not specifically mentioned by the son. He was completed 5 cycles of the whole brain radiation therapy in 1 week. Was given hormonal therapy for the cancer, for the brain metastasis. However, the progress of the treatment was not really well responsive according to doctor. So another contrast CT brain was done on March 2023 also at HUSM to further assessment of the progression of the cancer. Well, on April 2023, noted was the second admission of his second hospital admission at HUSM for 1 week. From 11. Sorry. Okay. Second admission, which is started from 11 April until 16 April. He was electively admitted for CT-guided lung biopsy to confirm the diagnosis of lung nodules, either to rule out the primary lung cancer or to rule out any a differential of lung metastasis from the prostate cancer itself. So he was admitted to White TD and for treatment of advanced prostate cancer with distal metastasis and given T-dexamethasone tapering dose as per oncology prescription. Sorry, not yet. On May 2023, it was his third admission of the year in HUSM. This time he was admitted due to complaint of passing blackish stool with blood clots for 3 days. Initially he was come for the onco follow up, but he was at some complaint to the doctor where he passing quite amount of blackish stool and also blood clots. So from the clinic he was advised to refer to the ED, and from the ED he was treated as lower GI bleed, also associated with fever, however no chills or rigor. It was intermittent in nature, and the temperature documented was 38 degrees Celsius. So during his stay for 1 week, on his third admission, colonoscopy was done, and they detect there is lower GI bleed due to the rectal ulcer. So currently it was his fourth hospitalization due to the respiratory symptoms. Noted that he was also was on chemotherapy treatment due to his confirm of lung cancer, which is the right small cell lung cancer. So on 8th June 2023 was his first cycle of chemotherapy done. Yeah, that's all for past medical and surgical. So we can move on for family history. So for family history, he was youngest out of 4 siblings. Her parents had passed away, where her father passed away at age 60 due to medical illness of renal calculi, while her mother passed away at age 90 due to the old age, while have no medical illness. The eldest brother also passed away at the age of 90, which is very old, due to asthma and had positive COVID-19 contact. Patient sister, which is 70 years old, diagnosed with diabetes mellitus and hypertension, where she currently on medication and follow up at KK Besut. Her sister also, which is 80 years old, currently alive and well with no medical illness. Patient was married to his wife at the age of 24 years old, and it was his first and only marriage. It's not consanguineous. They were blessed with 6 children, which is 4 boys and 2 girls. Currently 40 years old male, 39 years old male, 36 years old male, 34 years old female, 31 years old male, and 38 years old female. And all his children denied of having any chronic or non-medical illness. Next, please. For social history, previously he worked as farmer, but after knowing the diagnosis, or after knowing about his illness, he was no longer working for the past 5 years. And in terms of financial, uh, according to the son, they didn't mention of any financial problem. However, the family income was currently supported from currently and mainly supported from his children, especially from patient's daughter who currently working under government. So she one of the big contributor in covering the medical bills, medical bills, and also need to pay by patient and other family members. Um, for his lifestyle environment, he lives in single-story house at Kampung Nangka Besut with his wife and his two sons. His house is well equipped with good electricity and water supply. His wife, 60 years old housewife, is currently taking care of him in the ward together with their son. If at home, his wife and two sons at home taking care of him at home because he was bedridden, or we can say that he was fully dependent ADL. He was so all the dressing, cleaning, and taking medication um was done by his wife and also children. He was ambulated with wheelchair but still able to comply to appointments, follow-ups with his family support. And the distance from their home to USM was about 1 hour. However, there's no complaint of about logistic problem. Next, please. Sorry, before this slide. Okay, patient was a chronic smoker. So he an ex-smoker now. He smoked 20 cigarettes per day for the past around 20 years, which in his 30s uh, he was already smoke. He was already a smoker, and however he denied of any history of alcohol consumption, also drug use. Patient was bedridden, fully bedridden. After post radiotherapy, noted there is some neurologic presentation where he had right-sided weakness on April 2022 last year. After that episode, patient had difficulty in communicating, as he can only speak some few words. His son noted that it's difficult to understand, but um, however, they can somewhat get what he wants to say. However, he still can move his left limb and follow the instruction. Patient was in terms of emotion, we on open further questioning. Patient was deal with some emotional heartbroken and sadness said by his son because he was dealing with 30 kg loss of weight throughout the illness since December 2021, which is the first time he was diagnosed with cancer. However, patient was not depressed and still looking on the bright side. Patient's wife was a bit stressed because the husband was all now bedridden and she needed to taking care of him, and it was um, emotional draining for her and her children, and, and, and her children, because patient was not able to walk and talk normally as he did before. However, they did not feel burdened at all and were very hopeful that he would have improvement in recovery in one day. Next, for drug history. For drug history, he had a drug history of taking some drugs which is prescribed by the hospital also. First is the tablet dexamethasone 4 mg once daily, tablet pantoprazole 40 mg once daily, um, tablet bromohexacione 8 mg TDS, tablet tramadol PRN. He was uh, there's no known drug allergy history. He took cough syrup and paracetamol from pharmacy to relieve cough symptom and fever. before he got admitted. Otherwise, patient did not take any kind of traditional medication, over-the-counter drugs, herbs, or other supplements. For diet history, according to the son, he only consumed chicken porridge or soft food for most breakfast, lunch, and dinner as advised by the doctor. However, no known food allergy. Um, Next, please. Then that's all for history taking. We move on to the physical examination. So before, yes, yeah.
Can either Ahmed or you summarize the history? Just give a short summary of the history so far, okay? Ahmed can do that, or you can do that. I don't want to be. Please just make a short summary of the history so far.
Right. Maybe.
I'll try, doctor. So, my patient Salah is 66-year-old Malay male, was presented with shortness of breath on the 24th of June. He was the shortness of breath was associated with cough, a productive cough, and fever. On admission in the ward, he was tachypneic and still suffering of shortness of breath episodes. And on chest X-ray in the ward, he presented with pulmonary effusion, which was resolved with pulmonary tapping, but was complicated by a pneumothorax that was found in his lungs. At the moment, he resides in internal medicine ward. His condition is stable, but deteriorating.
Okay. The summary wasn't accurate. However, the important points you've highlighted, so I think that's okay. All right. However, continue with physical examination.
All right, okay, so I'll continue with physical examination, but before we go into the general and also the specific, I would just like to note that there is some specific examination that we cannot perform, like neurologic, because he was unconscious during the clocking. So I tried to present whatever that actually makes sense for our physical examination. So for general inspection, I just put it as summary because due to his inability to obey command, so there are several inspection can be made. So he was lying supine, unconscious, and was in respiratory distress with evidence of tachypnea, supported by 1 flow. The hydration and nutrition was clinically adequate with the presence of the line. However, he was not in nasogastric tube. Granular attachment. There was a granular attachment on the left dorsum, and he was on high flow mass oxygen. There was chest tube drainage and urine bag attachment at the left side of the bed. Actually, the palm during inspection on the peripheral was noted warm. However, was looking in pale. Otherwise, there were no any remarkable abnormal findings on the peripheries. Vital sign reading was as follows. The Glasgow Coma scale was 3 out of 15, which is E1, V1, and M1. The pulse rate noted was 115 beats per minute with regular rhythm and adequate volume. As he was tachycardic. The respiratory rate was 34 breaths per minute, which is tachypneic. The BP was 85 per 52 millimeter per mercury, which is hypotension. The temperature noted was 36.8 degrees Celsius. The SpO2 is 100% under high flow mass oxygen, which is around 50 liter per minute. Which is flow for 50 liter per minute. For the glucose blood, the capillary blood sugar, the typo error was 70.5 millimole per liter noted. Next, please. So, moving on to respiratory examination. So, during inspection, you can see chest was moving symmetrically bilaterally with respiration. There's no any deformities like pectus excavatum or carinatum or chest recession was seen. There was chest tube insertion at the anterior mid-axillary line between the fifth intercostal at the fifth intercostal space. For the palpation, was not done since patient was unconscious and unable to obey commands. And for percussion, the noted downers on percussion at the left side of the lung on all lung zone due to the pleural effusion. And on auscultation, there was noted reduced air entry on lower zone and middle zone of the left lung. However, there is no additional bronchial sound was noted on the day of clicking and of the examination. For cardiovascular examination, on inspection, chest was moving symmetrically, bilaterally, with respiration. There's no any deformities, no visible pulsation, no surgical scars. On palpation, apex beat was not displaced. There's no palpable trills, no parasternal heave. And on auscultation, there's normal S1, S2 heart sound heard, and no additional murmur was heard. Next, please. So before I interpret all the investigation result, I can say on summary, my patient Mr. Saleh bin Hussein, a 66-year-old Malay male with history with underlying of advanced prostate cancer and also newly diagnosed of right small cell cancer lung. Was unconscious during examination. The vital sign was not stable as he was tachycardic, hypotension, with low BP on inspection. On respiratory examination, noted he was in respiratory distress. And on auscultation, noted there is reduced air entry on the left side of the lung, which noted on the lower and middle zone of the lung. However, there's no additional bronchial sound and no remarkable findings on other systems. So that's for summary of the physical examination. So we move on to before we take a concept, can we discuss about relevant investigation result? So I just put on some investigation that have the findings that may suggest he have lower respiratory tract infection. So he was sent for FBC, fluid blood count, and liver function test to trace the serum protein level. So the rationale is to assess the sign of infection or sepsis, to look for any sign of anemia, thrombocytopenia in case of septic shock, and to look for evidence of protein loss due to the pleural effusion manifestation. So the impression onto this investigation, where white blood count increased, that means this is infection. Platelet was low, indicates thrombocytopenia. RBC, hemoglobin and hematocrit level were decreased, where he noted anemia and can find the sign of anemia on physical examination where the hand where the palm was quite pale. For the albumin and globulin level was also dropped from the normal range. And he also was sent for sputum and blood culture and sensitivity and also acid fast bacilli um, assessment, where the ration is to detect any bacterial growth and also to check for any active TB, also to confirm the causative agent of infection. So infection was pus cell was there was pus cell more than 25. However, on culture sensitivity, there was no growth obtained, and on acid fast bacilli test there is negative result, and so far no growth was detected. For pleural fluid analysis to find the characteristic and likely diagnosis of the pleural effusion, noted that body fluid, which is the pleural fluid protein, was markedly elevated, suggests an exudative pleural effusion. The body fluid glucose and also LDH was increased, and pH was increased from the normal range. The chest X-ray, where we want to trace any consolidation or lung lesion, or any sign of infection. Also want to assess any complication due to the underlying lung cancer. And can you focus on this cancer for this X-ray? Yeah, okay, thank you. So as you can see, there is quite opacity at the left side of the lung. That may suggest there is consolidation at the all over lung zone of the left side of the lung. They also noted a bronchogram at the both of the lung, haziness at the perihyla of the both of the lung. So it may suggest there is traction consolidation due to the pleural effusion. Also might suggest case of pneumonia. Okay, that's all for the relevant investigation. Maybe we can move on to the ethical issue.
Okay. So I'll be continuing with the ethical concerns regarding Mr. Saleh case. So just to remind everyone about the ethical pillars, I'm pretty sure everyone already knows about the ethical pillars. So we have autonomy, justice, beneficence, and non-maleficence. So for autonomy, we have patients have ultimate right on what happens to them and their bodies. As long as the patient is competent and he is above 18 years old, he can have his ultimate right on what happens to them and their bodies. Informed consent to the treatment, including any risk or side effects of the treatment as well. For justice, any medical decision made by doctors should be fair in society and in law, which basically means that the doctor, when he does any medical decision, he needs to reflect upon how this medical decision would affect the society in terms of is it fair or not, and of course it needs to relate it to the law. For another point is equal distribution of resources and same quality of care for everyone. And then we have beneficence, which means doctors should practice good. What intervention or treatment is likely to have the best outcome for the patient. So we try to, any decision we make as doctors should always be for the benefit of the patient. And this comes to non-maleficence, which means, remember, that any intervention carries risk, also includes neglect or non-action, which means we try to do no harm to the patient whatsoever in our medical decisions. For the ethical concerns that I think are important to highlight considering this case is one, delayed treatment. Second is cost of treatment. Third is cancer patient. He's a cancer patient. And fourth, do not attempt resuscitation order, which I think is the highlight of the ethical concerns. First, I'll start with the postponed or late treatment. It was planned that the patient would go for chemotherapy during the present week, which is this week, but it was postponed due to patient. Sorry, this is a typo. Patients was unconscious, being unconscious in the internal medicine ward. So because he was unconscious, they couldn't transfer him to the oncology and do the chemotherapy. So I wanted to highlight 4 points, which I think is very important to understand. A delay is something is late or postponed, can be looked upon as either ethically good or ethically bad. So a delay isn't always 100% bad. It could be ethically good as well. Precautionary principle, which is a precautionary principle, is a principle which emphasizes the need to be aware of the consequences of an action or in an action. So we are not just thinking about the consequences of an action, but also an inaction. For example, if our patient here is delayed of his chemotherapy, but we are not doing anything, we are just continuing with other work, we are not considering how our inaction has also consequences. Third point is unintentional delays in diagnosis and treatment may be related to the physician's inability to really access appropriately needed diagnostic and consultative resources, which is very important to this case, as like we said, the patient is unconscious and we cannot access the treatment due to him being unconscious. But also this point is not just to this point, but it's general, as some hospitals, we can't afford the treatment, or it's not even available in the hospital. The last point is, nevertheless, when delay is not based simply on the precautionary principle, which we mentioned already, it is the professional responsibility of the physician to make an effort to resolve the delay and provide the patient the needed professional services. And this concern, it goes under both non-maleficence and beneficence, as in our inaction or action, as mentioned before, or non-action or neglect could be harm, and for non-maleficence we try our best to do no harm to the patient, whether we are doing action or non-action. And for beneficence is that we try to practice good and we try to benefit the patient whatever way we could, either intervention or treatment. Secondly, we have the cost of the treatment. So cancer treatment and management can be very costly, therefore may cause great financial burden to the patient's family. The patient guardian, which is the son, had to quit his job last April to look after his father. Although this patient's family did not have any financial problems regarding the hospitalization and the cost of treatment, but I thought it's a very important point to mention regardless. So it goes under beneficence. A doctor has an obligation to act for the benefit of the patient and support several more rules to protect and defend the right of others. Therefore, the role of a doctor would be to investigate the financial background of the patient in detail, to consider individual circumstances so that better decision can be made and help to ease the burden of the patient and his family. We could also contact medical financial partnerships that could help the patient and his family. Also, there is a point that I thought is very interesting, which is justice, which is in this case is equal distribution of resources and same quality of care. I saw that in multiple pages online that justice can be very debatable in terms of as an ethical concern. For this case, for example, it could be argued that prioritizing cancer patients mean you're limiting the ability of other patients to access healthcare. That's the point. That's an argument. The other debatable argument is that a counter argument might be that by referring these patients to specialist oncology centers, you're actually freeing up other services. So I thought it's a very interesting point that you could search later on and understand more if you're interested. And I thought this is a very interesting table that just shows how the cost of cancer treatment of different cancers is very expensive. For example, cancer of breast is 99K ringgits, cancer of male genital organs is 24K, and so on. So it's very, very expensive. For cancer patient, the cancer patient near the end of life, common ethical dilemmas include those dealing with artificial nutrition and hydration, and truth-telling and disagreements over management plans. As cancer patients, especially patients who are dealing with metastasis all over the organs of the body, then a lot of medical professions are going to assist this patient, not only one doctor or two doctors, maybe even more. Therefore, a lot of decisions are going to come up, and that's why ethical dilemmas and decisions always come up with cancer patients. So it would stand that the clinician in good state to be aware of these issues and have an approach toward dealing with such problems. So at the end of the day, whatever decisions come between all these doctors, it should goes under the ethical pillars, especially non-maleficence and beneficence. Also, you can read more about that in the link below. This is also the link is an article that was written by a Malay professional doctor. And as you can see, there's a lot of ethical issues. All of these ethical issues listed here are related to cancer patients. For example, nutrition, hydration near the end of life, respect of the conflicting imperatives would be respect for autonomy, usually at the request of caregivers and the incompetent patient. And then we have non-maleficence, which is not proven to prolong life of stroke patients, and so on. So there's a lot of ethical issues that can come up with cancer patients, and these are the most common ones. Which you can, obviously I can't read all of this, but I did give the link underneath so you can relate to your patients in the future, or you can read it in your own interest. These last but not least, the don't attempt resuscitation. During the patient's ED admission at HUSM, the guardian of the patient, which is his son, who is the 5th out of 6 children, as mentioned before, he signed the DNAR, which is not attempt resuscitation order, after he understood the explanation from the doctor present at that time about his father's condition and how deteriorating it could be, how deteriorating it is, and how it could lead to the need of a CPR, for example, if he had any cardiac arrest. Therefore, the doctor at that time wanted the patient to understand the do not resuscitate order, as the patient already had history of multiple cancers like brain cancer and prostate cancer. So let's start with what is a do not resuscitate order. It is a type of advanced medical directive written in advance by patients, not to perform resuscitative measures in the event of cardiac or respiratory arrest, like CPR, for example, or electrocardioversion, for example. Second question is, who can sign a do not resuscitate order? Like we said in autonomy, this is an 18 or above competent person who has the right to make decisions concerning his health and medical treatment. Of course, in this case, the patient is unconscious. Therefore, we go to the next of kin, which is his son, who was with him at that time. He was his guardian. Now, of course, the son is the 5th out of 6 children. So if we think about it, we need to contact the eldest, the son, but at the end of the day, the son is 18 or above. And the doctor at that time also advised him to share the info and to try to discuss the decision of signing the do not resuscitate order with his family. And that's what he has done. Can a patient prevent the doctor from resuscitating him or her? The patient's right to refuse treatment is recognized by the Malaysian Medical Council and its guidelines. Consent to treatment of patients by registered physicians guidelines recognized. So clause 17, every person has the right to refuse medical treatment regardless of whether the reasons for the decision are rational, irrational, unknown, or non-existent, which also lies under autonomy. For the fourth question, why do patients sign a DNR order? So it could be for multiple reasons. The first reason would be personal factors reflecting lifestyle or health status. The second would be relational factors, either to family, relational factors, either to family or society as a whole. The third one would be philosophical factors, reflecting what they felt to be appropriate. This may include patients who wish to be relieved of their suffering, or they do not wish to on their family members in caring for them. Also, points that I wanted to highlight about CBG's point of DNR. CBG, there is a form called CBG end-of-life DNR developed by FIC. The end-of-life DNR CBG permits the actively dying patient to die with dignity, as well as giving clear clinical direction for practitioners. Engaging in futile treatment such as CPR doesn't respect the end-of-life choices agreed as a part of the advanced care planning. These choices are not made lightly, and the clinical judgment of a medical practitioner will significantly influence the decision of a DNR. The CBG also requires practitioners to have recent and reliable evidence from a clinical source stating that the patient is not for resuscitation to permit withholding of CPR following a request for emergency medical assistance, like a 999 call. You can read about that also in the link below. So I think that's it for our presentation. Hopefully you did understand more about the ethics and how it can relate a lot to any patient, especially DNR patients, for example.
Thanks, Ahmad. Can you bring us to your first slide with the patient's details first? But of course, please give Ahmed and Haifa a round of applause for finding a suitable case that address backs. Okay, not this one. The start of your presentation slide. You have patient details. Yeah. I just want to highlight an important practice for the future. Okay, for future, when you present a case in a case conference and settings such as this, always use patient's initial. Don't provide full name. Just put, for example, here SH. That's more than enough. Okay. Always protect privacy of the patient. You know, we may know the patient. Some of your colleagues may know the patient, but you know there will be others who don't know. So don't advertise their identity this way. Okay. So remember that.
Yes,
so even the informant also put, say for example here, just put MH rather than full name and things like that. Okay, but otherwise it's just a reminder next time when you share information openly like this. Okay. All right. And then if you move to your history slide, as you were going through the history slide, always remember presenting illness and history presenting illness should be about that. So we rarely put other information that is not related to presenting illness, but we can put that, say, under systemic review or past medical history. Okay?
Okay.
Just make sure you do that and then keep going. Putting information in chronological order is fine, it's good. Keep going. And then at the end of the history, before you move to physical examination, always make a habit of having a summary of the history. So that's why just now I mentioned that your summary of the history is not accurate. And then when Haifa read a prepared text on the history also, it wasn't accurate. Okay. Accurate means what? Accurate means you have the relevant positive from the patient history and then also a couple of relevant negative at the end of the summary for the history. And the relevant negative, usually some differential diagnosis. even though this case looked like relatively straightforward because of the underlying cancer, but still, when you call a patient, you need to have some other alternative diagnosis in mind. Okay, now keep moving to the physical examination. I think it's straightforward, although there are. Where did I? Next slide. Next slide. Okay. I think for physical examination, you must also, at least on the general examination, just go back, make sure that you comment on pressure points, okay, on any breaks on the skin and things like that, because patient is now bed bound, and patient has been bed bound even at home, isn't it? So make sure you don't miss that. Yeah, make sure you make a remark that you did look at any pressure points as well. Okay, next. As for the results of investigation, because you already highlight to everybody the patient has underlying advanced prostatic cancer, so you should have a report of PSA, last known PSA result. Then you mentioned patient may have a metastatic brain lesion, so you should put a report of the last CT scan that was, established this diagnosis. So all that should be here as a summary. You don't have to put in detail, but at least everyone is up to date with what investigations a patient has, relevant investigation patient has had in the past, and investigation that patient just had on this current admission. And lastly, before you go into the bioethical concern, then you must highlight what are the main issues related to bioethics that you find relevant. You should highlight that first, rather than, if you go to your next slide, rather than quickly jump into the 4 pillars, for example. Now, this list of ethical concern, as you had explained, true, there are, especially point number 3. Of course, we don't say a specific diagnosis such as cancer can be of ethical concern. That's not accurate, okay? But rather, what the example of a journal article that you share, a more appropriate way of saying these are the possible concern or challenges with regards to cancer.
The care of the cancer.
Especially end of life, end of life pathway. That would be the better way of saying it.
Yeah.
So don't give the impression that cancer patient is a bioethical concern. Yeah. Okay.
Oh, makes sense.
So, all right. Go back to the list again. And then similarly, number 1 and 2, we cannot say that these are concerned unless a family, for example, case number 1, a family sued the hospital because for whatever reason, specific treatment that can be life-saving was not instituted. And the patient suffer from either significant disability or functional loss or even death. Then the hospital gets sued as a result of the delayed treatment. Now, in this case, delayed treatment has nothing to do with intentional, reasoning on the doctor's part to deliver the treatment. So it's not a bioethical concern. You understand or not?
Yes, it has to be like a crucial treatment that could affect the patients in a very critical way.
True, Ahmed, but we are referring to the situation that we deal with this patient. So therefore, the situation in which this patient is faced is not a form of bioethical concern, because the delay in offering the chemotherapy is not because intentional. It's because patient is not fit for it.
Yeah.
Rather than we don't want to offer treatment. You understand that?
Yes.
So therefore, delayed treatment doesn't apply here. This is what I'm trying to say to you.
Yes, I truly
And then
understand.
point number 2, 60% of patients that come into USM will fall under this, meaning they can't afford specific treatment. You understand?
Yes.
So therefore, we never talk about cost as being a bioethical concern. So
Mm.
otherwise, anyone, 60 out of 100 patients who come in, it becomes relevant to them. You understand or not?
Yes.
So we don't feature cost as part of the bioethical
Ethical.
concern.
Mm.
Correct. Okay.
Mm.
So the only one that is very obvious in this case is the decision about to resuscitate or not to resuscitate. And a good thing about your history taking just now is you highlight the functional ability of the patient before illness, during illness. So this is important because we are determining the quality of life in the patient who has a terminal illness. So therefore, a decision on not to resuscitate or to resuscitate really is something that probably has been discussed with the family before, or with the patient. Patient already have what we call advance directive. The patient already clearly say what his wish was, in the event the heart is stop beating and things like that. So things like this should have been communicated early, not on day 6, for example, of admission, especially since we know already the patient has an advanced metastatic disease. Got that?
Got it.
Okay. So that's why DNAR or NFR, not for research, is not always a bioethical concern, but can be a bioethical concern where doctors want to save life, but legal representative of Nexoskin is telling you, during his life, he already said not to resuscitate him. But you as doctors at the same time know that he can benefit from the negative treatment that you're giving. He has a potential to recover from his acute illness, for example. So you
Influence.
has a conflict with the patient's wish or the family's wish. And then this is a less straightforward do not resuscitate situation. You understand that?
Yes.
Everyone understand this?
Yes, doctor.
All right, great.
Yes, doctor.
Okay.
Yes,
Now,
doctor.
another important point, this is the last point. Never forget mercy when you assess such a case. I didn't see that you attempt to use mercy to appreciate, to assess, to appraise this, what are the potential bioethical concerns. So in other words, you've got the history, you've got the examination, you've got the investigation. So you then think about what are the bioethical concerns from the mercy point of view. Then you address which one stood out and which pillar is the most relevant for you to discuss, be it autonomy, beneficence, non-maleficence, and or justice. All right. Is that clear, everyone?
Yes. Yes.
Great. Great.
Prof.
Now, in the next batch, I will provide a case, and I will split you into 2 groups for group discussion and then group presentation. Okay. I don't know when is that. When is the next session that I'm supposed to have with you? Is it on the 9th of July? Sunday on the 9th of July, isn't it? Okay, and what time is it usually scheduled? In the afternoon? Yes. All right. So on the 9th, I am fixing it for your class, 9 to 2:30 p.m. And I will communicate with Ahmed on the class link, etc. Because I have it. He has been contacting me for this class.
Okay. Okay, Prof. Yeah.
All right. Okay, that's all. Anyone has any specific question about this case that they want to raise? All right. No, if then great. Once again, please give a round of emoji support to Ahmed and Haifa for the good job. and highlighting and revising, my ethical concern with everyone. Okay, that's all for today. I'll catch up with you next Sunday. My mentee, please stay in the room for our session. Thanks.
Okay.
All right. Thank you so much, Prof,
Thank you so much, Prof.
for your time.
Thanks a lot, Prof, for the session.
Appreciate the care. See you soon.